Good morning, everyone. I'm Dr. Manvi Kalra from the Department of Radiodiagnosis and Imaging, Kasturba Medical College, Manipal. My topic for today is diverse neuro-radiological phases of melioidosis, a case series. Melioidosis is an infectious disease caused by Burkle-Holderia pseudomyeli, a gram-negative saprophytic bacillus found in contaminated soil and surface water of tropical regions, with endemicity in Southeast Asia and Northern Australia. India, particularly its coastal and agricultural belt, is an increasingly recognized endemic zone with a growing number of reported cases from South India and coastal Karnataka. Transmission occurs through inhalation, percutaneous inoculation via abraded skin, and ingestion of contaminated material. CNS involvement in melioidosis is uncommon, occurring in approximately 4% of cases, but carries significant morbidity and mortality. Fever and neurological deficits, particularly cranial nerve palsies, are the hallmark clinical presentation, and the brainstem is the primary anatomic site of predilection. The neuroimaging spectrum of neuromyelitis is wide and overlaps considerably with other granulomatous infections such as tuberculosis, fungal abscesses, as well as neoplastic and demyelinating conditions, posing a significant diagnostic challenge. The aim was to illustrate diverse imaging patterns and emphasize the inclusion of melioidosis in differential diagnosis for both focal and diffuse neuroinflammatory conditions. This case series describes 4 patients managed at our hospital who presented with diverse clinical and neurological manifestations and underwent MRI brain evaluation. The cases collectively illustrate the full breadth of imaging patterns encountered in neuromyelitis and emphasizes the role of early diagnosis. Starting with my first case of a 54-year-old male who came with complaints of acute febrile illness, delirium, gait unsteadiness, headache, seizures, and bilateral vision loss. A contrast enhanced MRI was performed, which demonstrated multiple well defined altered signal intensity lesions with adjacent perilesional edema seen involving the left high frontal region, bilateral parieto-occipital temporal lobes, involving the region of optic radiations, and extending to involve the splenium of corpus callosum bilaterally. The lesions demonstrated smooth peripheral rim enhancement with central areas of diffusion restriction. Mass effects were noted in the form of effacement of the adjacent sulcal spaces and compression of the posterior horns of bilateral lateral ventricles. In view of the above findings, possibility of tuberculosis, likely caseating granulomas with central necrosis, was raised. Chest and abdomen screening was performed for TB, which was negative. Later, a biopsy was performed from these lesions, and on aerobic culture, it came back positive for Burkle-Holderia pseudomyeli. Next is a case of a 51-year-old male who came with complaints of knee pain. He was diagnosed with septic arthritis and blood cultures came back positive for melioidosis. He later developed altered mental sensorium, and a CMRI was performed that showed intraaxial T2 and flare hyperintensities along bilateral corticospinal tracts, internal capsule, cerebellar peduncles, and brainstem, showing patchy diffusion restriction and subtle post-contrast enhancement. So, possibility of disseminated melioidosis was raised and the patient was started on antibiotics. Third case is of a 69-year-old male who came with complaints of recent onset altered behavior and had a prior history of subcutaneous melioidosis. A MRI brain was performed which demonstrated few conglomerated ring-enhancing altered signal intensity lesions at the gray-white matter interface of the left frontal lobe. Adjacent nodular dural thickening and enhancement was seen, suggestive of pachymeningitis, and the overlying cranium showed altered signal intensity and patchy enhancement, likely due to focal osteomyelitis. The patient was started on antibiotics and improved. Last case is of a 32-year-old male who came with complaints of drowsiness and loss of balance since 3 days. He had no history of fever and recovered from COVID a few days back. On MRI, ill-defined T2 flare hyperintensities with T1 hypointensity showing patchy diffusion restriction and post-contrast enhancement involving the subcortical and deep white matter of the left frontoparietal lobes, bilateral superior cerebella, peduncles, thalami, and brainstem was noted. Nerve involvement of the callosopeptal interface as well. No leptomeningeal or pachymeningeal enhancement was identified. Hence, possibility of demyelinating disease and edema was raised. The patient was started on IV steroids. However, there was no improvement. A repeat blood culture was sent, which came back positive for melioidosis. The key imaging findings of neuromelioidosis includes tunnel sign, which is characteristic, in which extensive flare hyperintensities are seen tracking along the white matter pathways and the brainstem. Multiple conglomerated ring-enhancing lesions, which show patchy diffusion restriction and a distinct hypointense frame on T2 weighted imaging. A brainstem and peduncle involvement is noted in many cases, mimicking demyelinating disorders. On MR spectroscopy, a lipid lactate peak and elevated choline levels are noted in the affected regions. The differential diagnosis includes CNS tuberculosis, fungal abscesses, metastatic disease, demyelinating disorders such as multiple sclerosis and edema. The overlapping imaging findings underscore the importance of including neuromelioidosis in the differential diagnosis of any patient from an endemic tropical region presenting with multifocal CNS lesions, especially when white matter tract involvement is noted. Management includes antibiotics, initial intensive intravenous phase followed by eradicative phase lasting for 3 to 6 months is given. Surgical drainage is indicated for large abscesses. The cases collectively demonstrate the full spectrum of MRI findings ranging from ring-enhancing conglomerated abscesses with calvarial osteomyelitis and pachymeningitis to corticospinal tract encephalitis and demyelination mimicking white matter lesions. Recognition of these characteristic patterns, particularly white matter tract involvement, brainstem predilection, and contiguous calvarial or meningeal spread is critical for early radiological diagnosis. The diagnostic clues are ring-enhancing lesions at the gray-white matter junctions and signal changes tracking along the white matter pathways. Um, these are my references. Thank you.